Good morning. Firstly, sorry we can't be there in person, but thank you for giving us this opportunity to present the results of our international survey, which looks at the outcomes that matter to patients, and importantly, how these results should be used to personalise the care of people with ALS who require home mechanical ventilation. My name is Judith Livingston, and I'm responsible for the ventilation programme within Air Liquide Healthcare. We conducted the survey across 12 countries where Air Liquide provides home care services. In total, over 3,600 patients responded, 656 of which had neuromuscular disease. Globally, across all of the disease types, the three most important outcomes were the same. That is, being able to breathe well, being able to sleep well, and feeling comfortable with the equipment. What is important here is the level of importance. That varied by disease, as did the order the outcome was selected. Communication was only seen in the top 6 for people with NMD, with 31% selecting this versus 13% for other disease types. As well as the variation in outcomes, we also found significant difference between patient types. We found that compared to non-neuromuscular disease patients, NMD patients were younger, 36% were below 45 years age, used their ventilation for more hours, 38% used it for more than 16 hours, and they also received more nursing care, 62% versus 27%. We also found differences in the outcomes selected between countries. Here we're looking at neuromuscular disease patients across 8 countries. We believe cultural differences and the type of ventilation, so invasive or non-invasive, influence this. These results have given us a great starting platform, but what is key to understand is why these outcomes were selected, how they interact and how they influence each other, and how we as a home care provider can positively influence them. I'd now like to hand over to David, our Director of Patient Quality of Life and a clinical psychologist. David.
Hello, everyone. Thank you. As Judith was mentioning, we wanted to, when we got these outcomes, these conclusions, we wanted to understand better what is happening, what is the relation with these outcomes. So we proposed to do and the best way to know this is to ask the patients, to ask the persons. So that's why we do this survey, these interviews. The purpose was getting feedback from the neuromuscular patients, the ALS patients also, on the results found. And then we wanted to, in the way we did is to do interviews by telephone or Meet interviews, Google Meet, to 5 patients, during 30, 45 minutes, and we took 2 caregivers also. This is the interview that we organized, we created. We wanted not to only ask directly about the outcomes, we wanted to understand what is the outcomes in the context of each patient. So there are 3 blocks about the life, how is the patient, what do you think about these outcomes, and how should we improve the mechanical ventilation. So we wanted to know, after to understanding the outcomes, what should be the way that we integrate these outcomes in our care plans. This is the characteristics of the 5 patients. We have 1 women and men, and from 27 to 64. And you can see different type of the therapies, all with mechanical ventilation, but with all other therapies like COX assist or aerosol therapy. It's very interesting to say when I present the results of the survey, and then I ask, what is the spontaneous reactions? They say the breathing is the most important thing. Depends how the disease affects you. This outcome is not the same depending on the status of the disease. Ventilation at the beginning is very scary. Many people look at, when the other people look at them, they think, I see the pity and worry and fear in their faces. And the family, the caregivers are key for this treatment. About what do you think about breathing well, I choose some conclusions. Some, for me, was very, very interesting reactions as well. The most important thing to be able to live. And then other persons, he says, breathing influenced me to be able to speak as well. Sometimes I don't have the strength to speak. So it's not only a question of to live, it's a question that it affects other areas in your life. About being able to sleep well, they say this is the most important thing for me. From what I have experienced now, feeling comfortable allows me to sleep. So it's important thing sleeping. This is more, I choose one question, but was one answer, but it was more or less all the patients were, the conclusion was that for all of them, sleeping well was key. About feeling comfortable with the equipment, with the device, they say that when they saw the device gives them, it's a wow, a lot of respect, but you need it. And if you is not adapted to you, or you are not adapted to the device, you are not comfortable. It was very interesting this, because they were saying that if you is some kind of what I understood from them is like if you don't feel comfortable, you will not be able to breathe well, and you will not be able to sleep. So all the outcomes were not at the same level. It was more or less that you need to adapt, and then you will be able to achieve the other outcomes. About feel safe while using the ventilator, they say if you don't feel safe, you cannot be comfortable and you cannot sleep. It was very interesting to see how they were able asking the patients, they were connecting all these outcomes between them. And about feeling control on my treatment, the patient, he prefers to talk about having control of my illness. It's not really the treatment. They feel that treatment and illness, the disease, is connected. So we cannot understand the things independently. We need to understand what is the context, the status of the disease, and then we will be able to understand what is the status of the treatment. The global impression of the outcomes is that the main barrier they found to improve these outcomes is the disease itself. It's a progressive disease, so you need to be able to adapt all the time. And the adaptation is in both senses, the treatment to the disease and the disease to the treatment all the time. So it's really, it's more complex. We cannot, as I mentioned, we cannot understand the treatment independently of the treatment, of the disease. Other thing that they mentioned is the shock, how the therapy was presented. There was some kind of lack of communication. You need this, and they put, and they need, they present the therapy to the relatives before to the patient, and they would like to be part of this discussion from the beginning. This is connected about the communication, empathy is super important, and they found that they are lucky with the people, the healthcare providers. They feel like it, but the most important thing that they found from them is the communication, the empathy. And they mentioned one important thing. Okay, these outcomes that you found in the survey depends of the situation that you have in the disease. It's not that if you don't have symptoms, you are in the advance, maybe these outcomes will change. The conclusion from the patient's perspective is that sleeping is something that everyone has worried. So we need to take into account the sleeping, with of course breathing, but the sleeping is key for the patients that they have this treatment. The outcomes are related to each other, and it's some kind of, as I mentioned when I was explaining the results, it's like some kind of connection between cause and effect between them. This improvement of the outcomes is related to the feeling in control of the treatment. So information, training, and adaptation to the device, and the adaptation of the device to the patient is important. So for me, there is one sentence, the right treatment in the right moment for the right patient. So this is super important. So we need to understand the patient to be able to see when he needs the treatment and adaptation, and then we will provide the best treatment. Three topics, three conclusions: training, coordination, home hospital, and different persons, we need to individualize of the treatment. What we have learned, and when we try, after these interviews and the conclusion, we sit all together, Jude and I, all the team, we say, okay, now what we have learned. If tomorrow we want to deliver a personalized care plan, what we have learned with the ALS, with patients with ALS. We have the diagnosis, and not all the patients have the same status. So we need to understand what is the functional status. Taking into account this, we need to empower the patient and the caregiver. It's super important to empower. And when we talk about empower, we are talking about information, training, communication, empathy. We talk about all these things. And we need to take into account other part of the context. It's in orange, the non-modificable influences. It's not the same if you live in a small town, in a big town. It's not the same if you live in a country when you have a lot of healthcare resources and you have a country when you don't have it. So we need to take into account this context also. After the empowerment, we will be able to achieve the first two outcomes that matters to patients: comfortable with equipment, feeling safe. In the moment that we achieve this is when we will be able to get good adherence to the treatment, good clinical outcomes, AHI, reduce the leaks, reduce the anxiety, and promote the caregiver implication. And thanks to that is when we will achieve good clinical outcomes and the other outcomes that matter to patients: breathe well, sleep well, minimize emergency services. And that is when we will be able to maximize the quality of life. So this schema is super important to understand, that help us to understand which actions we need to do. Treatment with mechanical ventilation in ALS patients is not a punctual and only one single moment. It's a process with different stages. What we propose after this is it's necessary to create this proactive care management program. We need to create outcome-driven care plans. If the outcomes are okay, is when we know that we are doing the things in the right way. It's not only a question of clinical outcomes. It's not only a question to have good saturation. It's a question of feel comfortable, feel safe, sleep well. So to maximize this quality of life, we proposed this personalized care plan with these 5 pillars. We need to information provision, patient navigation, help the patient to move, this coordination between hospital and home, care coordination. We need to be coordinated, all of us. At home, we are the bridge. We need to help the patient and the caregiver to connect with the hospital. Process monitoring. We need to check the right outcomes to be able to adapt the care plan depending on the status of the outcomes. And we need to do then this proactive monitoring and of early detection of signs and symptoms. We cannot wait until the problem is big. We need to be able to detect early when it's a problem. So what are the key takeaways? What we'd like to share with you all this experience, because at the end we really like to what we have the care plan that we are building, because we did from scratch, but going from the patient's voice, for the patient point of view. With what we have left is that to do these personalized care plans, we need to take into account the patient situation, what is the status, what is the context, and we need to create profiles. The profile is a generic cluster of groups of patients, but we need to be able to see what are the right profiles. And we need to adapt this care plan according to the status of the outcomes. So thank you.
Thank you so much, and thank you, Judith, for joining us. Are there any questions to start out? There are some questions. There's one down here. There's one over there. I'll start while they get the microphones. First of all, this was fantastic. Such a large study and such a lot of great information. Since communication was such an important piece to people, is there any looking at the masks to enable like a microphone or incorporate some way that people can still communicate?
I'll be honest, we haven't actually taken this to look at what impact it has on equipment, but actually you raise a very good point that often it is the mask and the equipment itself that impedes that communication. So actually you've triggered something now that I can certainly take to my counterparts in the companies that manufacture the devices to say, hang on, what can we do here? I think that's a very good point.
Thank you. And who has the microphone over here?
Thank you for the presentation. My name is Tommy. I'm based in the Netherlands. I was wondering, you had quite a lot of people globally that using non-invasive ventilation, and you have interviewed like 5 people on top of my head. Like, do you or can you show some light on the effect it had where people were living across the globe, or did you have like these 5 people were there from a certain region, and do you think that will the region where they live that will reflect or that will be reflective in their answering?
Certainly the country had a huge impact, or we believe it does, in terms of the global outcomes. The interviews that we have presented you today, they were all from Spain. So David who's Spanish, kind of was able to use his network to carry out those interviews. But I do believe that if we would take 5 more patients from, let's say, South Korea, where we noticed that the outcomes selected were very different to those that we saw in Europe, I think we would see different or get different feedback from those patients. And we believe that difference is both cultural, but it's also potentially linked to the use of invasive ventilation versus non-invasive. So if we looked at what equipment patients had and how they were using the ventilation, we could see the difference between the outcomes that were selected. So I don't know if that answers your question.
Yes.
Hi, Euphrosyne Young from SUNY Upstate, Syracuse, New York. My question is very specific for non-invasive home mechanical ventilation. When you defined patients that reacted in a way that the use of home mechanical ventilation is felt to be unsafe, I wondered what are the variables that contribute to that feeling of being unsafe with home mechanical ventilation. Let's say there are patients that have very poorly controlled oral secretions. There are patients that have loss of mobility and loss of arm function particularly, and they're not able to adjust the mask, for example. Are those the type of patients that are reporting to be unsafe? And because your patient population that responded to the survey are from Spain, and I understand that there are regional differences and geographic differences, are these patients having access to care of home care respiratory therapists that are able to assist, with problems, troubleshooting for, any issues with the mask, with secretions, with titrating the mechanical ventilation settings? I mean, what is the type of intervention that's happening in the homes? Thank you.
Okay, so maybe if I start with the type of support all the patients involved in the survey had. So we were only able to conduct the survey where we as a home care provider currently do these services. So we went directly to the patients that we currently manage. So in terms of that, they already had a home care provision. But the home care provision today is very limited, and we walk in the door and we look at the device as opposed to the whole patient and how the device works with them. And that's really what drove us to do this survey. It was interesting when we did the word wanting to feel safe came across from all countries. So it's clearly a feeling that people with ALS, they want to feel safe. Now, when we did the interviews in Spain, nobody said I feel unsafe, but they want to feel safe. And I think for all of us to assess that, I think one of the key drivers is really looking at their home environment in terms of the level of support the patient receives. So, for instance, one of the patients in the interview, his father was actually a doctor. So for him, safety wasn't an issue because he almost had a doctor in the bedroom next door all 24 hours. But for other patients who maybe lived alone, they had access to us via the telephone with help with the device. But really it's that I'm here in my house on my own. Somebody may come and give me some care, maybe a few hours a day. But away from that, do I feel secure enough? And the other thing as well was also the knowledge about the treatment. So people are given ventilation. Most patients today are initiated in a hospital environment. And there you probably feel safe. You're surrounded by medical staff. But when you go home, it's a big change. And it's how we support the patients. And David talked about the empowerment, so that caregivers and patients feel empowered and really understand that they can control their treatment as well. And that's why we believe that really the empowerment is what drives patients, and the knowledge and the training to help people feel safe when they do go home.
Excellent. Anyone else? All right, then we're going to go ahead and thank you very much for this excellent presentation.